difficulties when you're trying to do something, isn't there? Right, so we're recording now. Sorry about that, everybody. So welcome to this follow-up WebEx. So as hopefully all of you know, at the end of April this year, we got together and we had a meeting to discuss frailty and how we can support frailty in our areas for the whole northern region. And so as a follow-up to that, we wanted to get together just to see how everybody was doing, whether there was any issues people were having, and actually to update everybody on what we've been doing locally as well. So I'll just get underway with all of that. So there's just a very quick agenda of what we're going to be doing, so I'll just give some feedback from the event, what happened. Hopefully you might have read the report to have an idea of what I'm going to say already. And then we've got Jenny from North Kirklees is going to talk about what they've been doing in that CCG around frailty. And then there's going to be some work on what the national offer is and what they've been doing at NHS England to try and get frailty into national policies, etc. And then there's going to be a good Q&A session at the end. Times might be a little bit more fluid than it says, but we'll just play it by ear and see how it goes. I'll definitely make sure we finish on time because I'm very aware that you are very busy people. So just to make sure that you can all hear me, so if you can't, then please do go to communicate and dial in so that you can hear what I'm talking about. And again, if you have any questions, please do go to the Q&A section and type your questions in as you're going along, and make sure it's to all panellists so that we can all see what the questions are. If you want to have a chat to all participants, feel free to chat and make sure it sends to all participants so that everybody can also be able to contribute and talk about the issues that are going on around this, and maybe somebody else in the community might be able to support or help support those conversations. I'm going to start with some feedback from the event. So we got together in April to really discuss frailty as a whole, to look at what people are doing in the region, what examples of best practice are going on to support those people living with frailty, to make sure it's in people's minds as a long-term condition, not just something that happens to people, and look at what we can do as STP regions to support frailty kind of programme, what we can do, understand what we already have to know what's missing or what might need to be improved, and try and make what we have already in place better or more equitable or across our regions for our populations living with frailty. And so on the day there were 114 attendees, so thank you very much if you were able to attend. If you weren't able to attend or you were sorely missed. And we had a really good range of people that were able to attend, so from across the region. There's only 2 from the North East, but that's because they're running their own frailty event in September separately, along with some of their own programmes of work within that AHSN. And there was a really good range of people from across the system who were able to attend, so that we got a good system discussion going on in those workshops. So we had the acute care, we had the care homes, we had hospices, we had a good discussion across the whole care system and healthcare system. So I hope you can all see this because I know it is quite small, but yeah, sorry about that. So yes, so from the workshop, this is just a collection of what came out of these workshops and how they all joined together. So this is collating all of that information into just one slide so that everybody can kind of see. There were a lot of joined up working and joined up thoughts from a lot of the areas, and a lot of people were using the similar methods and similar things to support their populations already. Things such as like virtual wards or frailty teams, frailty clinics were already in place in all the STP areas. It might have just been that it's only in specific parts of those STP regions. So to actually understand that there's already somebody there is really good in understanding that there's somewhere to start from so that we can try and spread it out. And in terms of the actions, I think there were a lot of, again, similar themes and coming out of it, such as more joined up working. We need to educate people more on thinking of frailty as a long-term condition, not just as something that happens to people, and to actually get it into people's minds that we can help make these people's lives better if we move towards being more proactive about identifying frailty, so that we're not working on just being responsive when they have a fall, etc. So there's some really good feedback from the day, and we used Slido to try and capture some of that feedback and thoughts from there, and it scored very highly on Slido. We got an 8.2 out of 10, which I think is really positive, and we got some good feedback about getting the right people in the room and how it was interesting and intriguing, and how it felt to be very productive. So this WebEx is now feeding on to that productiveness and making sure that we keep momentum going and that we try to get everybody together to really discuss the issues, really. So I shared with you when I shared the report that there was a YouTube video. I'm going to hopefully try and play this now, so I really apologise if the sound doesn't work, but I'm really hoping that it will. So hang on a second.
So today is all about bringing colleagues from across the health and social care from across the North of England together to talk about frailty. There's 1.8 million people over 65 who have some form of frailty. And if you're over 65, then every year 1 in 3 people of that age category will have a form of some kind.
Frailty is a really useful concept because it helps us to identify a group of older people who have got reduced resilience and increased vulnerability, and so they're more at risk of having adverse outcomes, and so we can help to understand who those people are and how we can best support them, and how we can enable our families and carers and communities to support people as well. So what we're trying to do is we're trying to establish a framework, if you like, and a model for understanding frailty and the needs of people who are living with frailty. And one of the key sort of approaches there is to think about frailty as a long-term condition. We can try and minimise the impact that it has upon them and help them to live much healthier and more active lives.
It's great having events like this. It's great bringing people together, and there's been so much excitement and enthusiasm and conversation in the room. Crucially, is how do you bottle the energy from the room? How do you give people the ability to go back to their day jobs and not lose that enthusiasm and energy to make changes and to implement some of the great practices that they've heard of that's happening in different pockets of the North of England.
They do prescribe themselves exploring medications that a patient is on and whether it's still necessary for them to be taking that medication, and then through guided conversations exploring how maybe they could be taken off their repeat prescriptions.
So escape pain it stands for enabling self-care and coping with arthritic pain through exercise. So it looks very much at education for the participants, and also giving people strategies to cope and manage with their own pain and their own condition. And there's also an exercise element to it. So the unique nature of it is combining those three elements into quite a structured program. Escape pain is aimed at people who have chronic joint pain, generally due to osteoarthritis, and there's some really strong links between osteoarthritis pain associated with osteoarthritis and frailty.
We're at this Northern Frailty event today from a fire and rescue service perspective because we've seen all too often the disastrous consequences fires can have to people in the home. Frailty for us causes a challenge in the local area, so by working together with our health colleagues, with our health partners, we can make sure that our services are delivered to the right people in the right place and at the right time.
We need to develop a Frailty charter which sets out common standards so that we can identify where practice can be improved across the patch.
I've met a real disability frailty. That's fantastic. One of these really inspirational figures, but I've got a long list of things to follow up.
Right, so thank you for that. I'll just go back to the presentation. Hang on a second. There we go. So, as you can see, it was a really good day. There's lots of discussions, lots of positivity to the day, and we're really trying to focus on that positivity to try and drive this event today as well. And I really hope that recording actually worked. So the next part that we're going to showcase is actually what some people have been doing locally. Unfortunately, there were supposed to be two presentations, but unfortunately one of them had to drop out at the last minute, so I'm really sorry about that. But we do have Jenny on the call, who is going to talk about what they've been doing in North Kirklees around frailty and their frailty strategy. Hang on a second. Right, Jenny, so if you want to unmute yourself, and you've got control now of the screen. Jenny? Jenny, are you on the line? Okay. Jenny, are you able to?
Right. That's better. Hello.
There we go. Sorry about that.
It's all right. So you've actually got myself and Julie Oldroyd on the call today. Julie's going to take you through the development of our frailty strategy in North Kirklees, and then I'll pick up our programme structure and what we're doing next, so how we're taking it forward over the next year. So we'll take you through our slides. Okay. Hi everyone. This is the North Kirklees story then. So we started this work on the frailty programme about 2 years ago actually, and I think I was thinking back to what triggered the work, and I think we were looking at a virtual ward at the time, and we certainly visited Bradford to see their work, which was excellent, and from that point we started working with partners across the patch. We're only a small CCG, and we're part of 2 CCGs in Kirklees area, and we link with the Kirklees Council. So we brought together partners from the Hospital Trust at Mid Yorkshire, the Council, our CCG partners, and Wakefield CCG, to start discussing what a frailty strategy might look like and what are the key components. We developed a vision together, which you'll see. I think we've lost the slide. There we go. So key to our vision was that people are identified early with frailty and supported to live as safe and long as possible in their own home or in the place of their choice, and avoiding admission through this integrated proactive approach across the health and social care system. And much of our role has been facilitatory in this, in encouraging and working with others to kind of bring together this whole frailty programme. Part of the work, we identified some principles to work around. So we wanted to work, we wanted to do sort of from the earliest identification of frailty right through to end of life. We wanted to try and encompass the whole lot in our strategy. So that started with supporting people at risk of frailty and identifying people with frailty. And as the work unfolded, the EFI tool became available, so that's something we implemented with our practices. And also the core contract for GPs came into being for looking at severe frailty. So both those things have helped us move things forward, but we probably started with these principles before those happened. So alongside using the EFI tools to identify people at risk of frailty, we wanted to look at those people at risk and ensure early identification, and we certainly stumbled a little bit at this point in our journey, but now we use a Rockwood tool to identify anybody with a raised EFI score to confirm a frailty diagnosis and use REAT codes in clinical records to confirm that as well. We wanted to embed a care planning approach too. Care planning is something we've been doing over some years in North Kirklees. It's probably drifted a little bit because there's so many different understandings of what care planning is. So we wanted to kind of go back and be clear about all the different types of care planning and certainly incorporate end-of-life planning into our frailty programme. We wanted to make sure patients had a rapid access to services and specialist assessment where needed, and that's something we were looking at around this virtual ward model. And we wanted to make sure we did support people with moderate, severe and very severe frailty. We did want to include people with mild frailty as well in our strategy, and we have got some elements of that in the work plan. But we recognised we had to start somewhere, and we thought the focus should be with moderate, severe and very severe frailty initially, and then once we've got that working really well and processes in place, we'd try and work harder on the mild element. And the last principle we came up with, recognised frailty as a long-term condition, and this is something we've been working on over the 2 years, and I think now we can safely say our community provider and our partners in general practice are starting to see that, and frailty is now being recognised in such a way. We'll move on. We did develop some outcomes, and they'll be the outcomes everybody's expecting really around it, reducing any attendance and ambulance call-outs, etc. Although we did pick up loneliness as part of our frailty agenda, and that's something probably one of the newest elements that we need to work further on, and certainly falls. I think it's certainly in Kirklees we've been working on falls for some years, and we struggled to get the falls process working really effectively, but I feel now that with this programme we're making some way forward in that. And also we wanted to ensure that people with frail people who were identified with frailty have an annual review, and we wanted to certainly start identifying dementia and end of life at an earlier stage as key outcomes. Okay. This schematic's a bit complex, so I won't read it all out, but it's kind of trying to capture the whole programme on one slide. So it shows you the principles we've just talked through, and then the things we might do around assessment and mild frailty, and then the work we're looking at doing around a community frailty virtual ward for people with moderate and severe frailty, as well as what our vision is. But we'll move on from that because it's too complex to go into any more detail. We also tried to look from a patient perspective at what the outcomes would be for the patient around those 5-6 principles that we've identified. So this was an attempt to explain to the patient community what we think the frailty programme will look like for them. But again, I won't read that in any detail. These are just all the partners we've worked with around developing the frailty strategy. I have to say, bringing everyone together has been really helpful, and we were all working on frailty separately in our sort of organisations, and it's really important to share and ensure a consistent approach across, so this has been really valuable. I'm going to hand this bit to Jenny now, because Jenny's taken over the lead for frailty. I've done all the pre-work, and now it's Jenny's baby, so this is her bit, I think.
Yeah, so really we've tried to set up a programme approach really around the frailty strategy and to help us deliver this. So we've set up a frailty executive, which includes our executives from our partner organisations, so not just from the CCG, but also from the Acute Trust, Locala and the local authority. and that then feeds into our Frailty Steering Group, which has a wider range of partners that you can see on that slide, which also includes the sector colleagues. And then we set up really a series of task and finish groups and underneath that that are all responsible for delivering those different programme elements. So within that, we're looking at our care home support team, the Community Frailty Virtual Ward. We've got a scheme with our primary care team within their quality access scheme around identifying those severe and moderately frail patients. We pick up intermediate care and reablement, which also includes domiciliary care provision within there, looking at falls, prevention, loneliness, gender, and also end of life. So really there's a lot going on within the programme, and we've tried to set it up in that task and finish format really, so that actually we really focus on what we need to do. So you'll see in tiny writing underneath there, there's a bit of a summary of what each of those groups are doing really. And then really for us now it's about the next steps. So we're on a journey of integration with the council, and really we feel as though the Frailty programme needs to be part of that integrated approach across Kirklees. So we're looking at ways in which we can bring that Frailty Steering Group into more of that council forum, and looking at ways that we can have a truly integrated approach. As part of that, we'll be looking at how we can just refresh elements of the programme, strengthen our relationships across the Kirklees acute footprint, because we have two acute providers that we work very closely with. So we've got Mid Yorkshire and CHFT, so Caldervale Huddersfield Foundation Trust. And then we want to continue the implementation and development of our programme for this year and beyond really, and looking at it as what's working well, what can we learn from others really, what else is happening in our region that we can look at and think about in Kirklees. So we'd really welcome your feedback, what your learning is and what you're doing really as part of this as we continue that journey. So that was everything.
Brilliant. Thank you, Jenny and Julie, for really going through that for everybody. If anybody has any questions about their presentation, please put them either in the chat or the Q&A box, and then we can discuss them later once we get to the Q&A session towards the end of this WebEx. Right. So the next bit is talking about the national offer. So I wondered if Martin, whether you might want to please talk through the national support offer for the regions and how this work might be aligning to the development of maybe a long-term NHS plan. Let me just go to that. And let me just hope that this is...
Your line has been unmuted.
So Martin, can you talk? There's always technical difficulties in this, isn't there? Martin, are you dialed in? Are you able to present your slides? They're just here. Okay, so okay, so if Martin we can't hear Martin, I might just have to skip to the Q&A session for a minute and then we can come back to Martin. So Martin, if you can just go into communicate an audio connection and join the teleconference, please, and that way I think you should be able to get on. So I'll just open up the Q&A bit then, I guess. Another second. I'll just make myself the presenter again. So while we're just waiting, we'll just wait for Martin to dial in. I'll just open up the questions if anybody has any questions that they want to ask either myself or whether they want to ask anything to Julie or Jenny. Please either put them in the chat box or into the Q&A box. That would be really appreciated. Just give it a couple of minutes for people to write their questions. Right, so we have a question for Jenny. Is referral to exercise groups and stop smoking services part of the care package offered to people with frailty?
Yes, it is. So it's part of our review, and we're considering how we can link those areas into the programme and get them so that they're part of the offer from assessment, really.
But certainly, our primary care colleagues who are doing the reviews on moderate and severe frailty are often tagging those reviews to a long-term condition review if a patient's coming in for a routine annual review. So if they're flagged up as moderate or severely frail, the actual fuller frailty review will be tagged on, and part of that discussion is looking at all those things and doing care planning, individualised care planning with patients. If a patient identifies they want to do more exercise or they want to stop smoking, that will be part of their care planning discussion, and they'll be referred on as appropriate.
Great, thank you very much, Julie, for answering that. So I've got another question here from Lorraine. So it's, how can we ensure that frailty doesn't become a series of services rather than a cultural norm embedded in everything we do? So I don't know if, Dawn, if you might be able to answer that one. I don't know if that's more of a national question.
Can you hear me there?
Yes. Yep, we can hear you.
Oh, excellent. Yeah, no, very important point, and I think that's one of the things that we've been thinking about very much with the development of the Frailty Core Capabilities Framework, which you may be aware is hopefully due to be coming out certainly by the beginning of September, if not a little bit before. And starting to think about how do we embed this frailty approach, as it were, across everything that we're doing, not just across what we're doing, obviously in health and care, but what we're doing across our how we work with our wider partners, and how the voluntary sector, other public sector partners such as fire service, and our communities as well, families, carers, how do we all understand what frailty means and how we work together? So you're absolutely right. So it isn't just a series of separate things, and it isn't built around, if you like, just the medical aspects of frailty, but actually it is a, if you like, a concept that integrates into all the other work that we're doing. It's a cross-cutting approach.
Thank you very much for that, Dawn. Is there anybody else any questions for either Singund, myself, or Julia or Jenny? Before we move on to what the national offer might be.
We've just put in a question for Dawn. It was, do you envisage providing reviews for moderate frailty becoming part of the core GP contract going forward?
Dawn, what are your thoughts on this?
Sorry, can you hear me now?
Yes.
Yeah. So obviously, at the moment, as we stand at the moment, there are no changes planned for the GP contracts at this stage. But certainly, what we are looking at in the wider sense, not just around the GP contract, but is actually to start to build out what does that entire sort of coordinated and system, if you like, end-to-end approach to frailty look like? So what are the right interventions? And I think this is one of the things that Martin will hopefully be talking about if we can get him dialed in and his slides up. Is that the end-to-end approach, if you like, of frailty? So from the early identification and in that in the early stages of frailty, mild frailty, and older people who are still quite fit, thinking about the frailty prevention and how we can influence those trajectories of frailty, but then very much so thinking about what are the right interventions at each stage of that pathway. We've got an increasing body of evidence around what works at all those individual stages, and certainly building out if you like, moving out into the groups beyond severe frailty, which is obviously the current focus of the GP contract. Interestingly, I was at an integrated. This is actually in direct follow-up to the frailty event. I was up in Humberside last Monday with visiting an integrated care centre there, which and visiting in partnership with Humber Fire and Rescue, where I'm sure many of you be aware there's a brand new integrated care centre which just opened last week, where they've actually they're co-located with Fire and Health, which is obviously the first really exciting thing. But they've got a fantastic approach that they're developing there, where they've been focusing very much at this stage on providing those comprehensive assessments for people with severe frailty, but again already thinking about how do they work with the GP partners to start addressing the needs of people with moderate frailty, and what would that assessment look like? In what ways might it differ to the sort of assessment that they're currently doing for people living with severe frailty? So I suppose the short answer is that it's very much a work in progress. There's no plans at this stage, obviously. And as I say, there's no plans for changing the contract this year, but it's certainly that wider picture and how are the best ways to, if you like, to enable that change, and what does that look like, whether through primary care or other partners.
Great, thank you.
Right, brilliant, thank you. Right, hopefully, Martin, I can now present. So I'll just move on to that and then make Martin a presenter, hopefully. That worked?
Hi, can you hear me?
Yes, brilliant, thank you.
Had a bit of a Houston moment there. Apologies for that. Right. If there is an echo on the line, it's probably I'm dialed in twice, aren't I? Try to do that. Right. Okay. We'll try and battle through this. And thanks to Dawn for holding the fort there for a moment. So let me try and move this slide on, if I may. How do I do that?
You might have to go up to the top where it says pages, where it says, under where it says viewing Frailty standard deck.
Yeah, okay. Right, so we have formulated since the events a national support offer, which is summarised here. There's a bit more detail behind this, but just to perhaps reflect a little bit on some of the earlier comments, particularly the North Lees presentation, which I think pretty much captures a lot of what we're trying to do nationally. segmentation of the population by degree of frailty is extraordinarily important. I just want to emphasise that the Electronic Frailty Index, I think, is still perhaps not quite as well embedded in people's mindset as we would want it to be. It is a population segmentation tool in effect, and I was really pleased to hear that colleagues are now recognising the need to verify the person in front of them as being frail or exhibiting frailty, and also to use a validated tool to be able to identify the degree of frailty. From a population point of view, we want to start using the information that's coming out of the data sets that we're starting to generate to guide planning, particularly around the deployment of health and care resource. We want to use that to inform, as we go along, the size, scale, capability, capacity of the service offer. One of the things that came out of all 5 of the regional events was the fact that information governance and sharing at patient level remains a challenge, and I would suggest that systems need to think really quite hard about what information they're sharing, and also to try and make it as meaningful at patient level, but equally to keep an eye on all of the population level information about how much frailty exists within a local population, by what degree. And I'll come to why that is shortly. We're really keen to promote peer-to-peer networking and sharing. Again, that came out strongly in the meetings, and I think through the webinars we'll continue to see that. For those who haven't already joined, please do join the CAHOOTS platform, where a lot of information exchange is going on. It's a great environment for people to put up questions, chat, but also for us to keep in touch and to share what's going on. And I think increasingly that will become an important repository of what we're doing nationally, but also what colleagues are doing regionally and locally. We're keen to see the emergence of standards and ambitions, again, really encouraged by what's going on in North Kirklees. It does take a little time, and I think the amount that we can achieve in short time scales should not deter us from the longer term prize of capturing and managing those people in the population with the greatest degrees of frailty. This is largely about, I think, team relationships and information sharing more than anything, but it does take a lot of time to mature that up. We are very keen to support people living with frailty, but we're also extremely keen to try and look at the population health agenda and to promote active and productive ageing in a way that, for as many as possible, avoids the onset or delays the onset of frailty. Information, I think, will become increasingly important to this. We're coming towards the advanced stages of the right care frailty pathway, and colleagues in GERFT are also working hard at trying to establish the core data set that will enable them to establish a get it right first time pathway. And I think, again, for reasons of national priority, that is certainly in the first instance going to focus around the acute sector. But as we go on in this journey, I think it would be increasingly important to draw in community primary care, people at home, into the whole experience of care as it occurs, and to try and apply get it right first time methodologies through improvement as the offer at various stages along those pathways. I think we've got a long way to go with that, but I think we are making good progress and things are moving in the right direction. I've skipped over sequence and frailty currency, but I will come to that in a moment. In terms of where we are heading nationally, I want to introduce the Emerging National Policy Area of Integrated Care for Older People, or ICOPE, which is mirrored on the WHO ICOPE strategy, which is all about ensuring that people age well, but also for those who are losing functional ability to provide the right services and supports at the right time to maintain well-being through to the end of life. So our headline in that is supporting everyone to age well in the population. Many other partners in that, not least Public Health England. We will also provide comprehensive integrated care in communities. And again, I think some of the work that's already been talked about on this call, particularly from North Kirklees, that the model that's being adapted there is firmly in the centre of this area. We strongly recognise the need to work with, directly as a partner, equitably social care, and wherever possible to maintain people to live in their community both safely and with quality. We continue to want to use population risk stratification and then segmentation to identify those people who are most vulnerable to unwarranted outcomes. As I've already said, I think as we get more data available to us, more pathways data mapped, it will be much easier for us to assess about improving the offer in those particular discrete pathways of care, ranging from acute care to elective surgical care to oncology, and all other forms of experience of the healthcare system that people may have. We also want increasingly to tailor care interventions around individuals, and I think what we are very minded on nationally is not losing sight of what matters to individual people most, and that's very much about getting the precise care offer around that individual right in a time-sensitive way. Many of you will have already seen this slide, or parts of it. The channel shift that we're now looking for is focused on losing the concept of the frail elderly late presentation reactive services much more over towards early identification in a timely way, putting the care package in place in anticipation. Care planning is of key importance in that, keeping it community-based and person-centred wherever that is feasible, and ensuring that we make best use of acute care services. For the next few years, I think we're going to see focus on three particular models. None of this is new, you'll be reassured to know. On the right-hand side of the slide, we are keen to promote particularly moderate frailty, proactive intervention. This would take an MDT-based approach, very much rooted around the emerging primary care networks. Our approach here is intended to try and prevent people transiting up into severe frailty, whilst for those people where we can to demote them back into mild frailty in a way that improves their long-term prognosis, prospects and quality of life. We are also very focused on rolling out nationally the enhanced healthcare and care homes model as set out within the 2016 Vanguards report, and we are at the moment particularly focused also thirdly on emissions avoidance and reduction. Two parts to this. One is the enhancement of the offer around intermediate care, particularly the expediency of that, using national audit data, but also in counterpart with that to provide a better a more responsive offer in hospital pathways. This is about tuning up the hospital pathway to make it more responsive. So three things really. One is moderate frailty prevention. Two is enhanced healthcare in care homes, and then this third element of admissions avoidance reduction. And I think intermediate care is really, including reablement, is a key part of that. We're very keen to speed up the responsiveness of those services to expedite discharge from hospital. Part of that involves proactive identification of frailty at point of presentation. Just go on to the next slide, where this sets out the focus on acute care, particularly on length of stay, and this is in-year work. So on the left-hand side of the slide, the national ambition is to reduce those people who stay over 21 days by 25%. This will be necessary to free up adequate bed capacity going into next winter. We have two pieces of guidance which are now published and free to view. One is the NHS Improvement Guide to Reducing Long Hospital Stays, which sets out some of the narrative on the right-hand side of the slide. Just reference those three red boxes briefly. One is to routinely screen within 2 hours of presentation. We're keen to promote the use of the clinical frailty scale for that. To also look at functional need. I'm keen to look at things like the modified ranking scale to do that, which is very simple and quick. And then thirdly, to screen for cognitive status to improve the understanding of an individual's presentation in ways that we currently do not capture. Using that information then to identify those people who can be quickly de-escalated out of hospital to an improved community offer, but also actively managing their pathway through the hospital. And the key headline target there is to try and ensure that a person returns back to their own home to receive rehab and recovery within the first 20 days. Assuming that they are medically fit to do so. For those people who are severe, frail, with severe cognitive disorder, there is a particular need, I think, also for us to concentrate on whether or not that person has developed end-of-life care needs, and also to expedite delivery of that. The detail that is within the acute frailty same-day services guide, I would strongly recommend colleagues look at. This is a very useful brief guide issued by NHS Improvement just in the last week or two. And just to also highlight that in the bottom left-hand corner of this slide is the headlines of the Hospital to Home Community Health Services programme, which I chair, or governance part of it, I chair for NHS England. This is in partnership with multiple other agencies, particularly the care sector, NHS Improvement, and social care. We are seeking to promote healthy and active ageing, but also ensuring cross-sector working, namely integration, and the third objective is, which you probably can't see at all on that slide, is ensuring that timely transfer of care occurs using the methodologies set out by NHS Improvement. All of the above and much more is available on the Cahoots platform. If not already registered for that, please do so. Simply email the Clinical Policy Unit and they will grant permission to that. As I said already, it's a great forum, and very happy and pleased to see that Dawn's core capabilities framework gets pole position on the right-hand side. So it's things like this, as they land in the system, you'll be able to pick up, but also we want to see that as a two-way conversational platform. I shall pause there.
Great, thank you very much. Let me just steal back the presenter view in a second. Right, so we've got a little bit of time just for a couple of more questions if anybody has any following on from Martin's presentation. I have one already down that says, in addition to the GP contract, will there be any additional frailty-specific outcomes metrics that NHS England will be requesting from trusts? Matt, do you have any thoughts?
Yeah, I think right now the focus will be on existing metrics, but in particular ensuring in the acute care space that people do receive the best offer from their acute care. So 7-day stranded metric, but also looking quite assertively now at 21-day plus stayers. As time goes by, I think we'll be looking at other indicators, and I think particularly around falls, particularly around the responsiveness of the community services, and I'm thinking very much around the intermediate care services and reablement, and then also looking in due course at the offer around enhanced healthcare in care homes. The academic community is working hard at providing us with new tools, and one tool I'll just reference here that we are looking at is the hospital frailty risk score, which gives us an outcome measure from hospital, which works in very much the same way as the electronic frailty index does in primary care, but looks at HES data or SUS data to understand somebody's 30-day readmission to hospital risk, 30-day mortality risk, and also their risk of having acquired a previous long length of stay. So we're just exploring that at the moment. So I think, just to summarise that, all of the existing metrics that are in play at the moment will continue, but very assertively, I think, increasingly over the next 6 to 12 months, looking at acute hospital space, really trying to shorten those unwarranted long stays in hospital down by improving connectivity to community services.
Thank you very much. So, I have a couple of questions left. We've got 5 minutes left, so I'm sure we can get through at least a couple of these. So we've got, you mentioned the information governance challenges, resharing the information between health and social care. Do you have any examples of where this is working well?
I think it's fair to say that all of the working well examples are working well because of local workarounds. We have lots of data not necessarily being shared, not necessarily in the right place. Where we are able to link health and social care data sets, such as in Leeds, for instance, or in Kent, for population level management, that is extraordinarily useful. Maintaining an integrated data set for population health management, which has full access to health and social care data, is challenging, but some areas have been able to achieve that. And I would look towards the support of the academic health and science networks to work with local systems to achieve that. For local pathways, it is very much more than about having a system that works adequately to transit key data information. So again, going back to Leeds, we've got the example of the Leeds Care Record, for instance, where I think there is a local shared understanding of the need to share key pieces of information. What works in one area may well not work in another area, so I think it is local solutions. Looking for a national solution to this, I think will probably pass us by whilst we are engineering the solutions on local footprints. I think once we see primary care networks mature up, that those information sharing agreements on a population footprint of around 30,000 will become a lot more straightforward for local systems to make those agreements. It's not about sharing everything, it's about sharing what's most important to enable particular pathways of care work for individuals.
Brilliant, thank you very much. Hopefully this will be a nice easy one for Julie and Jenny. So are Kirklees planning on holding any events to share their learning in more detail?
Not at the moment. I don't think we've got anything planned. We're doing things locally with our practices at primary care level, but I think if there's feedback clearly that people would want to meet with us or have something, then we can look at setting something up. But we certainly hadn't planned to do an all singing, all dancing event.
No, but please just come to us and email contact for any information to pick our brains or to share anything good you are doing, because we want to learn from others as well.
Brilliant, thank you very much. So I think we'll move on now just to a few closing remarks. So I think the first one is, please do get in contact, please do join the Cahoots web page so that we can create this almost area of practice for discussion and to hopefully help improve services everywhere. You know, if there is anything that I can help with, or if there's anything that you have heard on this or at the event that you would like more information about, please feel free to get in contact so that we can share the right information, the right people, and get conversations going. Martin, Dawn, do you have any final words you'd like to say?
Dawn, ladies first.
Thank you, Martin. No, just to reiterate what you said, that please do get involved. Please do start those conversations on the platform. We're you know, there's just so much exciting work going on across the in the different regions and up and down the country. But please do sort of let us know and talk to each other and share experiences. And I'm going to shamelessly, Martin, put in another little pitch about the core capability framework. Once, you know, as all these new developments come through, as I say, the core capabilities framework being just one, it's really important that we hear from you how they're helping, what we can do to further support you, so that we can then understand what we need to do to keep building on this momentum, really.
And just from me, to say that we have an emerging national policy area around integrated care for older people. So I think this is possibly the first time that this has been achieved. We've got a long way to go with that, and in the first few years, whilst we're looking at perhaps up to 10 years of development of services, in the first few years, the key areas that we are wanting to concentrate on over and above what we're doing now are ensuring the acute care space works well for older people, that journeys of care through acute, be it elective or non-elective, are kept short, and to do that by ensuring the community services offer, particularly intermediate care, is effective, to where we can prevent moderate frailty progression, and then also to concentrate on care homes. So those three areas: intermediate care, care homes, and moderate frailty prevention through primary care networks, really key areas for the next few years. And as I say, really exciting time, I think, for those people with an interest in frailty, and in particular, a great opportunity for us to improve care for older people in this country.
Right, thank you very much. One final last thing for me to say is that yes, the slides and this recording will be shared out with those that have attended and those that weren't able to attend. So if you do need to share it around, please do, so that they're all aware of what's been talked about at this event as well. thank you very much for coming, and I'll let you get back to your busy days. Thank you.
Thank you, Maria. Thank you.